is a case of secondary adhesive capsulitis post-fracture. The patient is a 57-year-old male that had a skiing accident and sustained a 4-part non-displaced proximal humerus fracture treated conservatively. We saw the patient for the first time 5 months post-injury and had very limited motion and intense pain. An ultrasound-guided intraarticular cortisone injection helped him to get some pain relief and motion, but still at 7 months he was quite stiff, so we did consider that we could ensure an accelerated recovery process performing arthroscopy, arthroscopic capsular release. Pre-op motion was 0 degrees in external rotation, 85 degrees of abduction, 4 degrees external rotation in abduction, and 0 degrees internal rotation in abduction. So intense fibrosis was expected. Patient for surgery is a big chair position, and the classic posterior and anterior inferior porals are used for this technique. As you can see, we first opened the rotor cuff interval and checked the integrity of the long head of the biceps and rotor cuff. Arthroscopic capsular release was selective, involving release of the anterior inferior, posterior and posterior inferior capsule. Often we use the electrocatheter device. In this case, we knew about the presence of a malunited fragment of the lesser tuberosity that was removed, as you can see, and also we considered that it could be responsible of part of the pain and catching that the patient was suffering. We prefer the use of an arthroscopic rasp to complete the inferior capsular release while minimizing the potential damage for the axillary nerve. Risk of injury may also be reduced by the use of an arthroscopic biter in this zone. We then move the camera to our anterior portal and proceed to the release of the posterior superior, posterior and posterior inferior capsule in the same manner that we did in the anterior part of the shoulder. We also use the electrocatheter device trying to communicate our anterior and posterior release. As we said before, we must be especially careful in our release in between 5 to 7 o'clock position. After gentle manipulation, we can see now how the glenohumeral space is wider and less tight. This is here some of the rest of the capsule attached to the inferior humerus, and the last thing to do is checking the integrity of our axillary nerve at the 6 o'clock position in the shoulder.